Chapter 21, Eating Disorders, Part 1. The hypothalamus contains the appetite regulating center in the brain. It regulates the body's ability to recognize when it's hungry and when it's not hungry, or when it's satisfied. So some studies have shown that a dysfunction in serotonin levels as well as the norepinephrine levels can affect a person's eating habits. So there's a complex system, neural system, that regulates the body's ability to recognize hunger. So although nutrition is required for life, these neurons, this makeup of neurons, is really responsible for whether we actually feel hunger or not. Eating disorder is influenced by culture and society. Over the years, the woman's body was looked at as desirable or fashionable according to her size. So in the 16th and 1700s, the fuller sized woman, more plump woman was more desired. Then in 1920s, it started to be a more slender appearance. And in the 1960s, it looks like it went back to the more fuller woman. So throughout time, society has dictated what was more desirable as far as the woman's shape of her body, which influences eating habits as well. Let's talk stats. The lifetime prevalence for an episode of anorexia nervosa is 2.4 to 4.3%. Men account for 25% of those with anorexia and bulimia, and 36% of those with binge eating disorders. Bulimia nervosa is decreasing in the recent years, with a lifetime prevalence of 2% among women. Onset of bulimia nervosa occurs in late adolescence to early adulthood. Among college women, about 20% experience a transient bulimic symptom during their college years. It occurs primarily in society that emphasizes thinness. Binge eating disorder consists of recurring episodes of eating significantly more than most people would eat in a similar period of time under similar circumstances. And these episodes occur at least once a week for 3 months. So that sounds like something you probably should remember. The prevalence is estimated at 4% in the US. Obesity has been defined as body mass index of 30 or greater. 68.5% of adult Americans are overweight and 35% are obese. Anorexia refers to a prolonged loss of appetite. Anorexia nervosa is characterized by a morbid fear of obesity. Symptoms include gross distortion of body image, preoccupation with food, and refusal to eat. Body image is a subjective concept of one's physical appearance based on personal perceptions of self and the reaction of others. The distortion of body image is manifest by an individual's perception of being fat when he or she is obviously underweight or even excessively thin. Weight loss in clients with anorexia nervosa is usually accomplished by a reduction in food intake and often excessive exercise, self-induced vomiting, and the abuse of laxatives or diuretics may occur. Weight loss is excessive. For example, the individual may present to the healthcare um, professional weighing less than 85% of their expected weight. Other symptoms include hypothermia, bradycardia, hypotension with orthostatic changes, peripheral edema. They may start to grow fine hair similar to a neonate called lingo, and a variety of metabolic changes may occur. Amenorrhea is the absence of menstruation, which is usually followed by weight loss even before severe weight loss has occurred. Individuals with anorexia nervosa may be obsessed with food. For example, they may hoard or conceal food, talk about food recipes and length, or prepare elaborate meals for others, only to restrict themselves to limit the amount of calories of food intake. Compulsive behavior such as hand washing may also be present. Age at onset is usually early to young adolescence, and psychosocial development is often delayed. Feelings of depression and anxiety often accompany the disorder. We have a question. Which is characteristic of the diagnosis of anorexia nervosa? A. Obsession with weight gain. B. Body image disturbance. C. Disregard for the feelings of others. D. Healthy family relationships. You're correct. The answer is B. The distortion of body image. So the client may believe they're fat when they are actually severely underweight. Bulimia refers to excessive insatiable appetite. Bulimia nervosa is an episodic, uncontrolled, compulsive, rapid ingestion of large quantities of food over a period of time. This is called binging, followed by inappropriate compensatory behavior to rid the body of the excessive calories. So the food consumed during a binge often has high calorie content, a sweet taste, and a soft, smooth texture, and can be easily and rapidly eaten, sometimes even without being chewed. The binging episodes often occur in secret and are usually terminated by abdominal discomfort, sleep, social um, interruptions, or self-induced vomiting. Episodes of fasting and excessive exercise may occur for patients with bulimia. Most patients with bulimia are within a normal weight range. Some may be slightly overweight or slightly underweight. And weight fluctuations are common because of their alternating binging and fasting episodes. So depression, anxiety, and substance abuse are not uncommon with our patients with bulimia nervosa. Sometimes our patients will use not only self-induced vomiting, but also misuse of diuretics or laxatives or enemas to rid themselves of the excessive calories that they have consumed. And they are persistently overconcerned with their personal appearance, especially how others believe that they appear. Excessive vomiting and laxative or diuretic abuse may lead to problems with dehydration, electrolyte imbalances, as well as other health concerns. So vomiting, the gastric juices or acids will erode the tooth enamel. And in rare instances, the individual may experience tears in the gastric or esophageal mucosa. Some individuals develop calluses on the dorsal side of their hand, typically on the knuckles. This feature is called Russell's sign, after the British psychiatrist who first described it. We have ourselves a question. Which assessment finding would the nurse expect in a client diagnosed with bulimia? A. They are below normal weight. B. They binge when they experience hunger. C. They will be highly motivated to seek help. D. They are within normal weight range. And you are correct. The answer is D. Client diagnosed with bulimia nervosa are often able to maintain a normal body weight by purging after binging. Binge eating disorder, BED, is an eating disorder that can lead to obesity. So these individuals consume large amount of food in a short period of time. However, they do not purge, and therefore they sustain the weight and gain weight. So this eating binge occurs usually in less than 2 hours. It differs from bulimia nervosa because they do not engage in any type of behavior to rid themselves of the extra calories, such as purging or use of laxatives or diuretics. Predisposing factors. So our first factor is our biological influence. So genetics, so hereditary predisposition for eating disorders have been hypothesized. So anorexia nervosa is more common among sisters and mothers of those with disorders than it is among the general population. Biological influences continued. So there's been some speculation about a primary hypothalamic dysfunction in anorexia nervosa. Support for the primary hypothalamic dysfunction in anorexia nervosa is gathered from the fact that many people with anorexic experience amenorrhea before the onset of starvation or severe weight loss. Neurochemical influences in bulimia are associated with neurotransmitter serotonin and norepinephrine. The hypothesis has been supported by positive response by individuals with these diagnoses to treatment with SSRI drugs or selective serotonin reuptake inhibitor drugs. Some studies have found high levels of endogenous opioids in the spinal column of clients with anorexia, promoting the speculation that these chemicals may contribute to denial of hunger, and some of these individuals have been shown to have weight gain. Dynamic theory suggests that the development of an eating disorder is rooted in an unfulfilled sense of separation and individualization. When events occur that threaten the vulnerable ego, feelings of lack of control over one's body emerge. So psychodynamic influences, theory of Freud's, suggest that eating disorders result from early and profound disturbances in mother-infant interactions. So family influences. Historically, family influences were heavily considered. Parents were thought to be over-controlling perfectionists, which led to the child um, decision to starve themselves. But this has not been supported by any evidence-based claims. And our goal should be to incorporate the family in their treatment and not to blame the issue on family members. So, in the blaming of the parents has sometimes hindered the treatment or seeking treatment for their child eating disorder because they're feared that they're going to be judged as bad parents or the cause of the problem. So the clinician must have a good understanding of the body mass index or BMI in order to determine if an eating disorder is suspected. So 20 to 24.9 is our normal range for an adult. 25 to 29.9 is considered overweight. 30 or greater is considered to be obese. The average American's BMI is 26. And fashion models typically have a BMI of 18. Anorexia nervosa is classified by a BMI of 17 or lower. An extreme case of anorexia nervosa is less than 15.